Let's discuss about hypertension today. This is a must-know topic because hypertension is the bread and butter business in primary care. Non-communicable diseases, NCDs, is already the main cause of death in Malaysia and the biggest contributor in terms of disability life years, with high blood pressure the biggest contributor for both males and female. The latest National Health and Morbidity Survey, NHMS, for NCD risk factors in 2015 showed an overall prevalence of hypertension of 35.3% among adults 18 years and above. This is an increase from 33.6% in 2011 as compared to 34.6% in 2006. However, in terms of awareness, only 37.5% were aware in 2015, a drop from 40.7% in 2011. In 2006, the awareness rate was 35.6%. No significant difference between gender was observed. There was a general increasing trend in prevalence with age, from 6.7% in the 18 to 19 years age group, reaching a peak of 75.4% among the 70 to 74 years age group. Based on the 2015 survey, prevalence was the highest among other Bumiputras, 37.3%, followed by Malays, 36.4%, Indian, 34.9%, and Chinese, 34.2%. The relationship between BP and risk of cardiovascular events is continuous, consistent, and independent of other risk factors. The higher the BP, the greater the chance of myocardial infarction, heart failure, stroke, and kidney diseases. The presence of each additional risk factor, such as dyslipidemia, diabetes mellitus, or smoking status, compounds the risk. Therefore, the main aim of identifying and treating high BP is to reduce these risks of end organ damage or end organ complications. Hypertension is defined as persistent elevation of systolic blood pressure of 140 mm mercury or greater, and or diastolic BP of 90 mm mercury or greater, taken at least twice on two separate occasions. Although there is an attempt to redefine hypertension as 130 and or 80 mm mercury, the Malaysia Committee recommends that the old recommendation remains. It is of the opinion that the proposed lower definition will not change the way we treat our patients, particularly those with cardiovascular complications with BP equal to or more than 130 to 80 mm mercury needs treatment to lower BP regardless. Evaluation of patients with documented hypertension has three objectives. First is to exclude secondary causes of hypertension. Second is to ascertain the presence of target organ damage or complication. Thirdly, to assess lifestyle and identify other cardiovascular risk factors or coexisting conditions that affect prognosis and guide treatment. Such information can be obtained from adequate history, physical examination, laboratory investigations, and other diagnostic procedures. A complete history should include duration and level of elevated BP if known, symptoms of secondary causes of hypertension, symptoms of target organ complications, for example renal impairment and heart failure, symptoms of cardiovascular disease, symptoms of concomitant disease that will affect prognosis or treatment, for instance, diabetes mellitus, heart failure, renal disease and gout, family history of chronic disease, dietary history including salt, caffeine, liquor and alcohol intake, drug history of either prescribed or over-the-counter medication, NSAIDs, nasal decongestants, OCP, HRT, exposure to traditional or complementary medicine, lifestyle and environmental factors including air pollution that will affect treatment and outcome, and last but not least, check for presence of snoring or daytime somnolence, which may indicate sleep apnea. Physical examination should include general examination including height, weight and waist circumference, measure BP appropriately. Fundus examination, examination for carotid bluete, abdominal bluete, presence of peripheral pulses and radiofemoral delay, cardiac examination for cardiomegaly, signs of heart failure and aortic regurgitation, abdominal examination for renal masses and aortic aneurysm, neurological examination to look for evidence of stroke, and finally, look for signs of endocrine disorders. The minimum initial investigations aim to screen for presence of secondary causes of hypertension, determine the presence of CV risk factors, target organ damage, and target organ complication. They should include full blood count, blood glucose, renal function tests, creatinine, eGFR, serum electrolytes, lipid profile, total cholesterol, both HDL and LDL cholesterol, and also triglycerides. Check for uric acid, urinalysis, dipstick, albuminuria and microalbuminuria, and microscopic hematuria, and ECG. If the examination or investigations suggest the presence of a secondary causes, the patient should be referred for specialist evaluation. If there is evidence of target organ damage or target organ complication, further tests should be considered. This is a list of potential cause of secondary hypertension. Most common cause in my practice were Cushing syndrome and thyroid disease. Do not forget to look for potential target organ damage or target organ complication. Following initial clinical evaluation and investigations, the patient should be risk stratified. Many patients with hypertension have more than one other cardiovascular risk factor. Each additional risk factor increases cardiovascular risk substantially. Hence, overall global cardiovascular risk of a patient with hypertension should be done. According to a study in Malaysia, as many as 54% patients with essential hypertension did not have their cardiovascular risks adequately assessed. There are various ways to assess global cardiovascular risk, and this includes using validated risk charts, like the Framingham General Cardiovascular Risk Chart, which has been validated locally and found to perform quite well, or using risk stratification tables, which stratifies the risk of developing major cardiovascular events, which include stroke, myocardial infarction, and total mortality. After the risk stratification, namely low, intermediate, medium, high and very high risk, in which it indicates the risk of major cardiovascular event in 10 years. The patient should then be managed accordingly following the recommendation from this table. Once the treatment initiated, the patient should be followed up regularly. This table states the recommendation of follow-up duration based on the initial blood pressure measurement for adult. For patients who has normal blood pressure, they still need to be followed up at least once a year. Those who are pre-hypertensive, they are better be seen 3 to 6 monthly for global CV risk assessment. Now we have come to the management part of the disease. The management of hypertension is divided into two: pharmacological management and non-pharmacological management. Non-pharmacological management, also known as healthy living, plays an important role in the management of hypertension and in improving overall cardiovascular health. When recommending healthy living, it is important to know that these interventions require a joint effort from patient, family, and healthcare providers. Dietary interventions to lower body weight are often recommended for overweight people with mild hypertension. Weight-reducing diet has been shown to reduce blood pressure and body weight. A 4 kg reduction in body weight would achieve a BP reduction of 4.5 mm mercury systolic and 3.2 mm mercury for diastolic BP. However, the long-term effect of weight loss on mortality and morbidity in people with hypertension is still unknown. On the other hand, high salt intake is associated with increased risk of stroke, stroke mortality, and coronary heart disease mortality. Reducing sodium intake significantly reduces blood pressure in adults, where WHO recommends a reduction of sodium intake to less than 2 grams per day, or less than 5 grams per day of salt in adults. That is equivalent to about 1 teaspoon of salt. In Malaysia, the estimated mean sodium excretion of normotensive people was 3.4 to 3.8 grams, equivalent to 8.7 to 9.5 grams of salt intake per day. That means that we have exceeded the recommended salt intake and hence, salt reduction is recommended for most people, especially the hypertensive population. Alcohol consumption can also elevate the BP. Previous meta-analysis has shown that reducing alcohol consumption reduced BP by March 3 systolic and 2 mm mercury diastolic. A recent meta-analysis has shown that reducing alcohol intake lowers BP in a dose-dependent manner with an apparent threshold. Therefore, people who drink are advised to limit alcohol consumption to less than 2 drinks per day. Increased physical activity has been shown to reduce BP. However, there is a lack of data on its effect on cardiovascular events and mortality. Meta-analyses have shown that dynamic aerobic endurance, dynamic resistance, and isometric resistance training can lower the BP. All patients with hypertension benefit from any form of these physical activities. Cumulative moderate-intensity aerobic exercise of at least 150 minutes per week is advised. A diet rich in fruits, vegetables and low-fat dairy products with reduced saturated and total fat can substantially lower BP, which is 11 systolic and 6 mm mercury diastolic in hypertensive patients, and 4 systolic and 2 mm mercury diastolic in patients with high normal BP. A recent meta-analysis suggests that healthy dietary patterns, such as the dietary approaches to stop hypertension, also known as DASH diet, Nordic, and Mediterranean diet, significantly lowered BP. These diets are rich in fruit, vegetables, whole grains, legumes, seeds, nuts, fish and dairy products, and low in meat, sweets, and alcohol. A recent cohort study that included Malaysian population without cardiovascular disease has shown that higher fruit, vegetable, and legume consumption was associated with a lower risk of non-cardiovascular and total mortality. Next, smoking can raise BP acutely. However, the effect of chronic smoking on BP is less clear. Nevertheless, smoking cessation is important in reducing global cardiovascular risk. Last but not least, stress management is useful, but evidence on relaxation interventions on BP reduction has not been convincing. Yoga had been shown in a systematic review to reduce blood pressure by systolic of 4.2 and 3.6 diastolic, but the quality of evidence is poor. Now let's look at the pharmacological management. All patients must be risk stratified to guide the management. Decision to initiate pharmacologic treatment depends on the global cardiovascular risk. It is the reduction of BP, which provides the main benefits in the general hypertensive population. The choice of drug should be individualized. I repeat, the choice of drug should be individualized. For patients with stage I hypertension with low cardiovascular risk, advice should be given on healthy living for a period of 3 to 6 months. It is because pharmacological treatment has not been shown to prevent cardiovascular outcome in this group of patients. Patients should be seen at least twice, ideally monthly, during this period to assess the efficacy of the non-pharmacological intervention. However, stage I patients with medium or higher risk should be offered drug treatment upon diagnosis. In patients with newly diagnosed uncomplicated hypertension and no compelling indications, choice of first-line monotherapy includes ACEIs, ARBs, CCBs, and diuretics, which have all been shown to reduce cardiovascular morbidity and mortality. Let's look at ACE inhibitor. ACE inhibitors are effective antihypertensive agents which can lower cardiovascular risk, reducing mortality and morbidity in hypertensives and those at high cardiovascular risk. They are more effective in preventing coronary artery disease in patients with hypertension. ACE inhibitors are generally well tolerated and do not have adverse effects on lipid and glucose metabolism. Their safety profile is good. Adverse effects include cough and angioedema. In patients with renovascular disease or renal impairment, deterioration in renal function may occur. So, please check the serum creatinine and potassium before initiation and within 2 weeks after starting. If there is hyperkalemia, where the potassium is more than 5.6 millimole per liter, or a persistent rise of serum creatinine of more than 30% from baseline. Within 2 months, the dose of the ACE inhibitor should be reduced or discontinued. You can combine an ACE inhibitor and a dihydropyridine CCB, or a thiazide diuretic in patients with hypertension and high CV risk, where the CCB combination is preferred. Bear in mind, this class of drug may increase fetal and neonatal mortality and therefore are contraindicated in pregnancy and breastfeeding. ARB are drugs which specifically block angiotensin II receptors. Unlike ACE inhibitors, persistent dry cough is less, and as such ARB are recommended for risk reduction in ACE inhibitor intolerant patients. The safety profile of ARB is very similar to ACE inhibitor except for a lower incidence of cough. This table summarizes the available evidence on the therapeutics of RAS blockers in patients with various comorbidities. ACE inhibitor is still generally the preferred agent unless there is intolerance. Calcium channel blockers, CCB, are a structurally and functionally heterogeneous class of drug. The main mechanism of action is vasodilation, which decreases peripheral resistance in view of the effective BP-lowering property and excellent safety profile. CCB, especially dihydropyridine type, have been recommended as first-line antihypertensive agents. A meta-analysis showed that CCB reduced stroke in hypertensive patients more than placebo and beta blockers, but were not different than ACE inhibitor and diuretics. However, there is no evidence that dihydropyridine CCB are superior to other antihypertensive agents in Asian populations for the treatment of hypertension in reducing cardiovascular death, major cardiovascular events, stroke, congestive heart failure, and coronary revascularization. Beta blockers have long been used in the treatment of hypertension. They are particularly useful in hypertensive patients with effort angina, tachyarrhythmias, or previous myocardial infarction, where they have been shown to reduce cardiovascular morbidity and mortality. Beta blockers are not recommended as first-line monotherapy in this group of patients according to some guidelines. This was based on an earlier meta-analysis which showed that it is not as effective in lowering blood pressure and in the prevention of stroke compared to the other antihypertensive agents. However, more recent meta-analyses, including updated versions of earlier meta-analyses, have suggested beta blockers, especially the beta-1 selective, can be given as first-line agent. Almost all guidelines recommend that beta blockers should be considered in younger patients, in particular, those with an intolerance or contraindication to ACE inhibitors and ARB, women of childbearing potential, patients with evidence of increased sympathetic drive. Beta blockers are absolutely contraindicated in patients with uncontrolled asthma and relatively contraindicated in other forms of obstructive airways disease, including controlled bronchial asthma. It is also absolutely contraindicated in patients with severe peripheral vascular disease and heart block, both second and third degree. They are generally well tolerated. Adverse effects reported include dyslipidemia, masking of hypoglycemia, and increased incidence of new-onset diabetes mellitus. Diuretics, specifically thiazide diuretics, have been the mainstay of hypertension treatment, alone or in combination with other antihypertensive agents. Diuretics work via inducing natriuresis, which alter long-term sodium balance, leading to reduced peripheral vascular resistance and sustained blood pressure reduction. Diuretics provide synergistic effect to almost all antihypertensive agents, particularly RAS blockers. There were also outcome data that supported the potential cardiovascular benefits of thiazide diuretics, particularly in those with preserved renal function. Thiazide diuretics are classified into thiazide, example being hydrochlorothiazide, and thiazide-like diuretics, like indapamide. Locally, Hydrochlorothiazide is the most commonly used thiazide diuretic. Hydrochlorothiazide is effective in the range of 12.5 mg to 50 mg daily dose, but dose above 25 mg per day is more likely to cause electrolyte and metabolic adverse effects. In chronic kidney disease with eGFR 30 ml a minute, thiazide diuretics are less effective and a switch to loop diuretics is recommended. A recent case control observational study highlighted a significant increase in the risk of skin and lip squamous cell carcinoma among thiazide diuretics users. There was a clear dose-response effect with the highest cumulative dose of hydrochlorothiazide having the highest risk. There was more than 7-fold increased risk of squamous cell carcinoma for a cumulative use of more than 200,000 mg hydrochlorothiazide, equivalent to 50 mg daily for a duration of more than 11 years. So, actually, which drug is the best? There is no answer to this question because certain class of antihypertensive gives extra benefit to certain condition. Therefore, you can refer to this table, which shows the choice of antihypertensive in patients with concomitant conditions. Again, any agents can be given, just that certain agent is particularly good in certain patient of comorbidity. Efforts must be made to achieve target BP. For patients less than 80 years old, the target systolic BP should be less than 140 mm mercury and diastolic BP less than 90 mm mercury. For patients aged 80 years and above, aim for a target of less than 150 mm mercury systolic and 90 mm mercury diastolic. For very high-risk individuals, the target should be less than 130 mm mercury systolic and 80 mm mercury diastolic. If BP is still more than the target BP with 3 drugs, including a diuretic at optimal tolerated doses, there is a need to exclude medication non-adherence and isolated offers hypertension. After excluding these causes of uncontrolled hypertension, the patient is then defined as having resistant hypertension. I will talk about resistant and refractory hypertension later in the next presentation. If target BP is not achieved despite showing some blood pressure lowering effect with monotherapy, either increase the dose of the initial antihypertensive agent or add a second antihypertensive. Increasing the dose may, however, give rise to dose-related adverse effects. Properly selected antihypertensive combinations may also mitigate the adverse effects of each other. If the patient does not show response or does not tolerate the initial drug, substituting with a drug from another class is recommended. In patients presenting with stage 2 hypertension or beyond, combination therapy as first line is recommended. Combination therapy can be considered as first line in high-risk stage 1 hypertension, especially for secondary prevention. Have a look on this table about the effective antihypertensive combinations used in outcome trials. If you need combination and your patient is suffering from the specific comorbidity, you can prescribe as the suggestion given. Follow-up intervals should be individualized based on global CV risk, pre-treatment BP levels and drugs used. For high and very high-risk patients, it is advisable to bring the BP to target within 3 to 6 months. Once target BP is achieved, follow-up at 3 to 6 month intervals is appropriate. As a rule, once the BP is controlled, most patients will require lifelong treatment. Patients must be counseled to have at least 6 monthly follow-ups even though the BP is well controlled, and not to resort to merely going for repeat prescription without seeing a doctor. During these visits, doctors should assess persistence of BP control, adverse reaction to treatment, global vascular risk, and complications of hypertension which may have developed since the last visit. Most patients can be effectively managed by primary care practitioners. However, certain patients need to be referred to the appropriate specialists, including FMS, for further assessment. So, when should you refer the case? Indications for referral to the appropriate specialists include severe hypertension, suspected secondary hypertension, resistant and refractory hypertension, recent onset target organ damage, pregnancy, offers hypertension with additional CV risk, children and adults less than 30 years, and secondary prevention with multiple comorbidities or risk factors. Some patients will come and ask you about stopping the medication when their BP is well controlled. The answer is, step-down therapy is discouraged in the vast majority of patients. However, if your patient insisted on it, the following criteria must be considered first. Patient's BP must not be higher than stage 1 hypertension with low global CV risk, BP well controlled for at least 1 year on the same medication at the same dosage, must agree to be followed up at least 3 to 6 monthly, must be motivated to adopt healthy living. A recent systematic review done between 1975 to 2013 showed that a trial of treatment withdrawal in well-controlled hypertensives followed by subsequent regular blood pressure monitoring is safe with minor adverse events. Predictors of successful withdrawals were patients on prior monotherapy and lower blood pressures before withdrawal. This is the end of part 1. We will cover a bit more practical aspects of hypertension management in the next part.